Good evening, and thank you for joining us. My name is Dr. Alvarez Secord from Duke University Medical Center, and I have Dr. Tom Herzog with me from the University of Cincinnati. And it is my pleasure to welcome you here today. We are so excited to be involved in this educational webinar. This webinar is made possible through a generous, unrestricted educational grant from Clovis Oncology. Founded by the Society of Gynecologic Oncology in 1991, the Foundation for Women's Cancer, also known as the FWC, is the only national organization dedicated to all gynecologic cancer. The FWC works diligently to make the pathway of survivorship easier and to fund research to unlock new knowledge about ovarian and other cancers unique to women.
Angeles, thank you so much for having me join you tonight. We're really looking forward to interacting and talking about some of the latest developments in ovarian cancer. The development of a strong research program was a real driving force behind the creation of the Foundation for Women's Cancer. Many of today's leading gynecologic oncologists have received their first grant from the Foundation. If you would like to learn more about the Foundation for Women's Cancer, please do not hesitate to visit their website or contact the headquarter office. The FWC would love to hear from you.
Also, I would like to thank all of today's speakers, Tom, who volunteered their time to share information and answer your questions and hopefully impart knowledge that makes a difference to you. Tom and I do not receive an honorarium, and we give our time to be here with you. It is the policy of the Foundation for Women's Cancer to reveal any known conflicts of interest, and possible conflicts of interest include financial relationships or other affiliations with businesses or organizations that promote or sell products or services that are the subject of health information being discussed in today's course. And I do have conflicts of interest to disclose. We're going to be discussing several agents that are currently being used in women with ovarian cancer, being PARP inhibitors and another agent called bevacizumab, which targets blood vessels. And I have been involved in research clinical trials with these agents, as well as on advisory boards for several of the companies that develop these drugs, including AstraZeneca, Clovis, Tesaro, and Genentech. And Tom?
Well, interestingly, I have almost the same conflicts of interest. I also have served on advisory boards and as a principal investigator on studies, as well as on steering committees for studies for AstraZeneca, Clovis, Genentech, and Tesaro. Today's webinar will last approximately 1 hour, with the remaining 30 minutes reserved for question and answer and discussion. We greatly value your feedback on today's course. You'll have the opportunity to complete a brief evaluation of this webinar at the conclusion. We ask that you take a few minutes to complete this online evaluation, as your feedback will really help us in the future in terms of making these courses better and better over time. I think, Natalie, you have to go through a few things, but in the meantime, I want to thank you so much for sharing your evening with us, and I really hope that you leave today's program feeling that your time was well spent.
Yes, thank you so much. And without further ado, let's go ahead and get started. When Tom and I were talking about the talk and coming up with the title, we both really liked the title Ovarian Cancer. It's personal, because one of the things that's so important for us is our patients and their caregivers, and we recognize how personal this journey is for all of you. In terms of our objectives today, we have several. We'd like to review ovarian cancer, incidence, origin, and management.
We're going to discuss genetic testing, the who, when, where, why, and how, and the what.
Review current treatments for ovarian cancer patients.
We're going to enhance your understanding of individualized, personalized medicine for ovarian cancer.
So let's go ahead and get started and discuss ovarian cancer, the incidence, origin, and management. And I'd like to take a step back first and discuss how many cancers are estimated in the United States in 2017, and it's really an amazing number. Almost 1,700,000 new cancer cases will be diagnosed, and approximately 600,000 cancer deaths, and that's far too many. We need to halt this incidence quickly. But I wanted to also emphasize that ovarian cancer is a rare disease. There'll be approximately 22,000 cases of ovarian cancer this year. And ovarian cancer is it's not a common cancer in ovarian cancer. It's the 11th most common cancer in women. So it is a rare cancer. importantly, what we've seen is that the incidence of this ovarian cancer in the United States has declined. And that really makes me excited. I don't know about you, Tom, but to see this number decrease is fantastic.
It's encouraging for sure.
Absolutely. In 2013, there was a report that almost 200,000 women were living with ovarian cancer in the United States, and it really demonstrates that this cancer can represent a chronic disease, and women can be treated for a long period of time with our current agents. And we're also very excited about several of the agents that we're going to talk about today that have been recently approved for the treatment of women with ovarian cancer. As you can see from this graph, the incidence rates of ovarian cancer have been falling for the last 20 years. Tom and I wanted to show this slide and just represent the shifting geographic incidence of ovarian cancer. On the left, we see incidence rates ranging from 2008 to 2012, and the areas that are burgundy really demonstrate these high incident locations. And I was very shocked. I'm from Montana, so I was very shocked to see that Montana was so high. But the good news on the forefront is that graph on that figure on the right shows the incidence rates from 2009 to 2013, and we see these some of these hot spots declining. So you can see changes from that burgundy to pale orange in Montana, and then some of these lighter shades of orange going white. So if we can continue to reverse the incidence of this disease, that'll be fantastic. And I do think that we will, and Tom is going to talk about that a little bit later when we talk about genetic testing and how that can make a difference for patients as well as their families. So our big issue is understanding what causes cancer and understanding the biology about why this even happens in the first place. If we understand the biology, hopefully we can prevent it from happening. And on the left, you see this figure demonstrating the random errors that occur in stem cell divisions. So you can have these random errors that multiply on top of each other and leads to a click where then you have a cancer cell develop. And there's different types of errors. There can be hereditary errors, like the kind that you inherit from a parent. We're going to talk about that further with various types of mutations, specifically focusing on BRCA1 and 2 mutations. There can be these replicative errors, but also, importantly, these environmental associations with cancer development. And some of these we understand, like smoking for lung cancer, but we're also understanding the importance of obesity for other types of cancers. And there's a long way to still go forward in understanding what are the triggers for ovarian cancers. I want to back up a second, Tom, too, and just mention, because I think it's so important to mention that really ovarian cancer is not just ovarian cancer alone, but fallopian tube cancers and peritoneal cancers act the same way, and we really group these all together under the ovarian cancer umbrella.
Absolutely.
All right, so moving on, what are risk factors for ovarian cancer? Well, we already talked a little bit about BRCA1 and BRCA2 gene mutations, and we'll explore that further. There's other hereditary mutations in the Lynch syndrome, which is a constellation of several different types of mutations. A family history of ovarian cancer, even with negative testing for the known mutations, is still very important. So if you have a family history of ovarian cancer and you've been tested and you're negative, it may not necessarily mean you're not at risk, because there could be other genes out there that we haven't yet discovered. So just having a heightened awareness of that. A history of infertility, polycystic ovarian syndrome, definitely a history of endometriosis can increase certain types of cancers, clear cell cancers and endometrioid cancers, or low-grade serous cancers. Cigarette smoking, which I thought was really interesting, can increase the risk of another subtype called mucinous cancers. Intrauterine device, past use of oral contraceptive, past breastfeeding for greater than 12 months, a tubal ligation, and previous pregnancy. And actually the last few there are actually protective. So if you had a past use of oral contraceptives, if you breastfed for greater than 12 months, if you had your tube sites, those are actually protective. So you have to be aware that this list can comprise different things that increase your risk but also can be protective. Correct, Tom?
Yes.
Yeah. So I believe really in my mind when I think about risk factors for ovarian cancer, I'm thinking about that family history as certainly being one of the biggest risk factors in endometriosis. What about age? This tends to be a disease that occurs as women age, so mostly in women who are postmenopause. And the median age of diagnosis is 63. As you can see from this bar graph, it's really rare for women to have ovarian cancer if they're in their 20s or 30s. An important thing to know about ovarian cancer is that it's not all the same. There's many different subtypes. This pie chart shows the most common subtype is high-grade serous cancers. As you can see from this pie chart, high-grade serous cancers are represented by the yellow, and they comprise over almost 75% of the cases. And then we have these more rare types, such as low-grade serous or clear cell and mucinous and endometrioid. I don't want to confuse anybody, but endometrioid can also be high-grade and low-grade. For the purpose of the talk, Tom and I felt to keep it simple and kind of put endometrioid in that separate group. But the frequency of these cancers are much less, as you can see. All right, so this next slide we talk about, we're going to be delving into the cellular origins of ovarian cancers. We've learned that not only do these cancers look different under the microscope, they may come from different origins. So the high-grade serous cancers, as shown on the right side there, that figure, and the low-grade serous cancers, those cancers are probably coming from the fallopian tube. And it really takes, it took me a lot to get my mind around this, but the abnormality probably develops in the fallopian tube, and these abnormal cells are sloughed off of the fallopian tube, and they deposit on the ovary, and the ovary is the poor innocent bystander that gets caught up and blamed for everything. But but there may also be another pathway that some of these cancers actually do come from the ovary. So we're still striving to understand this whole process better. But that can have important implications in terms of preventive strategies, like removing the fallopian tubes. Can that prevent ovarian cancer? At the middle of that screen on the right are these clear cell cancers. They tend to have a clear cytoplasm and sometimes are commented on having this hobnail shape. And the cancer right below that are endometrioid cancers, and they look like the lining, the glands of the endometrium. And these cancers are thought to come from the actual lining of the uterus and may develop from retrograde menstruation. Many of you may be thinking, well, what does that mean? And that could mean that during the menstrual cycle, the blood flow goes out of the fallopian tubes and into the pelvic cavity. And that is one of the thoughts of how these cancers may develop. These cancers, as I mentioned before, tend to be more rare. And then lastly, these mucinous cancers of the ovary, we really don't understand those that well. That cell of origin is really unknown. Some people think it could be coming from the lining of the cervix. Other people think that most of these mucinous cancers aren't even ovarian cancers, that they're coming from other parts of the body, maybe the GI tract. So we still have more to know, but what's really great about understanding the origins of ovarian cancer is understanding the different treatment options and also prognosis. So the next slide I show is going to be a figure of how women do in terms of their progression-free survival. That means before cancer can come back, or even overall survival. And what you see here is that that yellow curve represents endometrioid cancers, and those cancers tend to act less aggressively, especially if they're low-grade cancers. And women with these type of cancers tend to have the longest survival. And then you have this group of serous cancers, and serous cancers, even the high-grade serous cancers that are the most common, they tend to be far more sensitive to chemotherapy, and that's probably one of the reasons that women live longer if they have this type of cancer. And the low-grade serous cancers tend to be slow-growing. And then we have the clear cell cancers and the mucinous cancers. And the mucinous cancers are shown by the red line, and those are just really challenging cancers to treat. And I think part of the reason is because we're maybe using the wrong drugs. So we're learning more about these different types of cancers and how to treat them. I do want you to take this slide with a grain of salt because this is really older data. I mean, Tom, this data comes from studies from over a decade ago, probably even close to 20 years ago at this point now, right?
Yeah, but it's really interesting because it's really our first foray into making ovarian cancer personal, and that just the cell type alone has prognostic implications. So it's interesting. And now, and we'll get into that a little bit later, some different treatment implications.
And it does help me counsel patients about what is their prognosis, what's the likelihood of responding to chemotherapy when we know this information. So the next step really was understanding what is really happening at the core in these cells that causes them to develop these cancers. So I want to turn your attention first to the right side of this slide, and you see a figure of the fallopian tube. Those finger-like projections are the fimbria of the tube, and this the Hg symbol is covering that ovary, but the stick tumors, which are these serous tubal lesions, have developed this initial mutation. They'll show these p53 mutations. As these tubal precancers develop and turn into cancers, then those cells slough off into the ovary. That's what that red curved arrow is trying to show, and then you develop this high-grade serous cancer that is often blamed on the ovary. And these cancers, in addition to these p53 mutations, will have often BRCA1 and 2 mutations, and they're also noted to have a lot of instability in their genetic makeup, and that's called chromosomal instability. We're going to talk about why that could be important in terms of treatment options. Now I want to turn your attention to the left side of that figure, the blue area there, and that really goes to the mechanisms of how these low-grade serous cancers can develop. And it's thought that they could develop from inclusion cysts involving either the tube or the ovary, or these borderline tumors, or from serous cystadenomas. And more work needs to be done in this area to truly understand the phenomenon, but you can see from the list of mutations there that they're completely different than the mutations in the high-grade serous cancers. They tend to have mutations in KRAS or NRAS or BRAF mutations, as well as HER2 amplification. And what the HER2 amplification means is that you just see a lot of that gene is just revved up and turned on. And what we can do now is use this information to try to direct the right type of treatment. So some of the newer drugs are actually targeting products of these gene mutations. So it's a really exciting time. And as we move forward into this next section, Tom is going to explore understanding more about the underlying genetic basis of these cancers and discussing genetic testing.
Angeles, thank you so much. It's really a pleasure to be part of this program tonight. And I think if we look at the implications of genetic testing and the background on genetic testing, each of these sections that we're talking about really could stand on their own for an hour. So we apologize if it seems that we're throwing a lot of information at you at one time, but we do want to certainly describe all the great changes that are going on and all the things that have emerged in the recent literature. So having said that, one of the things that has been very clear is that having a BRCA mutation has significant implications, not only prognostically, but now for treatment purposes. And we also have a better understanding of what that background is. So beyond just having BRCA mutations, we know that there are other important gene mutations that are associated with what we call homologous recombination deficiency, otherwise known as HRD. And so why this is important is that while we think that about 15 to 18% or so of patients may have a mutation in either BRCA1 or 2, we know that another small percentage will have mutations in the tumor but not inherited from their mother or their father. So mutations that arose anew, and we'll talk a little more about that. But beyond that are another group of patients that are sizable. And so what we're talking about is growing the pie, if you will, for patients that would be eligible for biomarker-driven treatments. And so this is an exciting time in ovarian cancer, and we'll give you some, I think, some pretty good information in terms of some of the things that have come out in the literature recently that have impacted that. So this is looking at inherited BRCA1 and 2 mutations present in all types of different ovarian cancers. And Angeles just went through the different types of mutations that are associated with different histologies. So you can see here the relative proportion of BRCA1, BRCA2, or other mutations that are present, and the MMR is mismatch repair. So as you can see, it differs a little bit by histology. We talked a little bit about mucinous, but even some mucinous tumors do have BRCA mutations, although it's more rare. The most frequent, as you can see, are these high-grade serous cancers, or carcinomas not specified, which often I think are probably serous tumors in the community that just aren't well characterized. And certainly, I think if you look at the the percentage of frequency that these occur, that supports that. So who should have genetic testing? Well, it's a bit of a busy slide, but really the answer is quite simple. What's the answer, Angela?
Oh my gosh, Tom is testing me. I personally think that everybody with epithelial ovarian cancer should be tested.
Correct. Yeah, correct. So we feel that everyone with epithelial ovarian cancer should be tested. Some have argued whether you could whether you could accept mucinous tumors. Our concern with doing that is, first of all, you will miss a few of those cases, and secondly, the other concern is that then people start getting into what are the guidelines and what are the exceptions, and then we'll see misapplication of the guidelines, and we're worried that people will get missed. But as you can see, a number of organizations that have issued guidelines or statements in this area, including the NCCN, the Society of Gynecologic Oncology, and ASCO, the American Society of Clinical Oncology, have all recommended in some form or another that women with epithelial ovarian cancer be tested. And we'll talk a little bit of why that is in a bit here. So what's the clinical value of doing genetic testing? Well, first of all, if it's positive, if we find that there's a germline mutation, in other words, there was a mutation inherited from your mother or your father, and I think a lot of people get confused that these mutations can actually come from the father's side.
That blows me away, Tom. I had a patient tell me that they didn't think she needed to be tested because it was her father's mother that had cancer, and I don't know where that myth got started, but for anybody on the line, you know, it's just like Tom said, you have to be really careful about both your mother's side of the family and your father's side of the family.
You can't choose your parents too carefully either.
No, or your children. But.
That's right, that's right. But it really is important. So what we're really emphasizing is that you have a thorough understanding of your family history in cases where we don't have ovarian cancer in the patient herself. If the patient does have an epithelial ovarian cancer, then irrespective of the family history, we believe that she should be tested. The benefit is, as we said, it is certainly very prognostic in us being able to counsel her expected course in terms of how she'll respond to treatment and so forth. And now we have therapeutic options that really revolve around the mutation being present or not. And so this is very helpful. It also can help identify cancer risk in other organs. It also will help us guide which trials you may be eligible for, which is really important. And then, very importantly, it helps identify other relatives who may be carrying this gene. So what's so important about this is it's really an opportunity for us to save lives and prevent these cancers from ever occurring in the first place.
Right, and I just wanted to add to that, you know, when we looked at the graph earlier and see that the incidence of ovarian cancer is decreasing, my thought is as we continue to do more genetic testing and identify individuals who have the mutation, that's going to lead to, you know, the cascade testing idea where then the relatives will get tested and will have preventative surgeries or preventative treatments, and that number of ovarian cancer cases will continue to decrease. I'm very excited about that.
Right, and we're focusing on ovarian cancer tonight, but certainly the ramifications for breast cancer and other cancers is significant, and we're certainly want to be mindful of that as well as we discuss this. Well, what if you don't have a germline mutation? You've been encouraged to have testing and you do not have a germline mutation. Well, certainly that could put you in a different strata in terms of what our screening recommendations will be so that we can most appropriately use resources and also use your own personal resources to not be overtaxed by over-screening if you don't carry the gene. And the other thing I think is there's certainly a lot of reassurance in terms of family planning and other things that go into that. So it can be very helpful in our opinion no matter what information that we derive. It really is one of those examples, I think, of knowledge being power. So what to test? Mutations can be germline or somatic, and that can be a little bit confusing. So as I said, germline mutations are inherited. So they, of course, would be present in every cell in the body, and that's what you see on the woman depicted in the left in the orange. And then the woman who's more in the gold or the yellow, you see there's the orange section where depicting down by her ovary in the pelvis, there is a tumor, and that tumor has a BRCA mutation, either BRCA1 or BRCA2. And so what I think is important is to have a better understanding of which of these is present. Currently, we're recommending that all women have germline testing who have epithelial ovarian cancer. In fact, there are a number of centers and a number of investigators now who will do direct tumor testing as well, and some have even advocated doing direct tumor testing and then reflexing then to germline if that's positive and so forth. So lots of ways that this can be done, and we don't want to get into the weeds too much on this because it's really such a fast-changing field. The recommendations are changing all the time, and it's basically because of our technologies. The technologies just keep improving, and they keep getting cheaper. So what was not possible 5 years ago is now entirely possible, and not only is it possible, it's now cost effective. And so that has certainly changed how we go about these things. So how to test? Certainly you can do single gene testing, or you can do multi-gene panel testing, and that gets into a little bit of identifying other genes that we spoke of with the first or second slide there in my section, where we looked at other genes that are responsible for making you susceptible to some of the new therapeutics that go after these mutations in DNA repair. And so one of the questions that was brought in is explain this whole concept of homologous recombination deficiency versus non-HRD, and it really revolves around our ability to look at these gene mutations and have a pretty good understanding of how well you're going to repair your DNA. And that's what this is all about, and we'll get into that in a little more detail here in a second. But if we look at the pros and cons of multi-gene testing, we usually use next-generation sequencing, so you're doing high throughput testing, and you can pick up a lot of other mutations that are present that we think are important, such as the RAD51 series, PALB2, some of the mismatch repair genes such as MLH1 and so forth. So all these we think are very important. You can look at these genes and have a better understanding of who needs cascade testing, prognostics for the patient, and then again, therapeutics. With anything where you gain more information, it can be good, but it can also be bad. So one of the things that we will certainly pick up with multi-gene testing is we will find changes that we don't really know what to do with. And what that means is we usually classify these as variants of undetermined significance or uncertain significance. And what that means is we can't tell if that gene mutation is going to cause you to be more likely to develop a cancer, and we may not even understand how that relates to your ability to repair DNA. So some mutations we know really have no effect, and so they're harmless, if you will. Other mutations we know are definitely involved, such as the ones listed there on the left. But there are other mutations where we just don't have enough follow-up data. And the good thing about all this is we collect all this information as we move forward. We have a better understanding of reclassification of these variants over time. So that's one of the big things that is done in terms of a research. The research context of the collection of this genetic information is that we use it to learn over time. So it's a learning system as we move forward. We're also causing a fair amount of anxiety, especially if we have these variants of undetermined significance and we can't tell you for sure whether it's good or bad. And then, of course, the more data, the more chance that there's a mistake or some misinterpretation that can occur. So all those things are problematic. Nonetheless, the general trend has been to move more towards multi-gene testing. It's become much cheaper than what it used to be. and we do gain so much more information. I don't know, Angeles, in your practice, do you really believe in that theory, or do you use it, or how do you employ multigene panel?
I think we've all moved toward multigene panel testing at this point because it is cost effective, right? That's the biggest thing. When I first heard about it, I was a little bit concerned in terms of, well, is this more costly to the patient? And it turns out it's not compared if you did a BRCA 1 or 2 evaluation first, and if that was negative, then reflex to multigene panel testing. I do think BRCA 1 or 2 are the big, those are the big frequency, the big genes that we're evaluating. These other genes are smaller frequency. I think it's also important to understand that these genes have different penetrance. If you have a PALB2 or a RAD51C, those aren't necessarily the same thing as compared to a BRCA1 mutation. And BRCA1 and BRCA2 are different, right? They have different penetrance, different timing in terms of when
different age of onset,
yeah, exactly.
Very different in
different
terms
prognosis,
of fertility
too,
counseling,
right?
and so forth. Yes.
But as I've done this more, and we have genetic counselors on our site, but I think it's important to discuss up front with the patient that if they do multigene panel testing, you might have this higher frequency of the variants or the genes of uncertain significance, so that they're aware. And if you do that counseling, I think there is less anxiety and confusion, but it also is very patient dependent. Some patients get really concerned and anxious about what it can mean, and other patients don't seem to have that same degree of concern.
Right.
So it's important to open the door to have the conversation.
Yes, I agree. So one of the questions is, why are we spending all this time talking about BRCA and so forth? And I think what's really important to understand is that your body has to repair DNA every day. So your body faces stressors that are out there in terms of environmental and so forth that occur where the DNA has to be repaired. And we have multiple pathways for doing that. And BRCA is one of the pathways that's critically important. The reason it is important is that it is a high-fidelity repair pathway, meaning that when it repairs the DNA, it does a really good job. So if a certain base pair is supposed to be put in, it does that at a very high accuracy rate. Whereas some of the other default pathways are not nearly as accurate, and they give rise to mutations that can be important. So why does it matter in terms of the tumor? Well, here you're looking at the years from diagnosis, and we're kind of crumbling up a lot of data there that you could really blow up and scale even more, because there's really a pretty big difference between the BRCA1 and BRCA2 patients in terms of how they do over patients that do not have a BRCA mutation. So if you look here, we're looking at a survival curve. The higher the curve, the better. That means you're surviving for a longer period of time. So on the bottom there, we have the years from diagnosis, and then on the abscissa there, we have the survival percentage. So I think that what's important is to understand that we think that this is a very strong prognostic indicator in terms of telling how a patient's going to do.
So, Tom, I always felt like this was so ironic. You have the mutation, right? You inherited the mutation. It puts you at higher risk for developing the cancer.
Right.
But by the same token,
you do better.
You do better, yeah.
Right.
And that's because you're more likely to have be sensitive to the chemotherapy drugs because of that inhibition,
right.
that inability to repair the DNA damage that the chemotherapy drugs do.
Exactly where we're going with this, right. So why does it matter? So this is looking at, as an example, from study 19, looking at olaparib versus placebo, but it just shows the difference of what we can do by adding what we now call PARP inhibition into the equation if you have a BRCA mutation. And to what you said, any DNA damaging agent is going to be more effective in someone who has a BRCA mutation, because remember, these mutations are present in the tumor cells. These are the rapidly dividing cells, and therefore these cells are unable to repair that damage as well as someone who doesn't have these mutations, and therefore we see a higher percentage of those cells respond to chemotherapy or to any DNA damaging agent. Now, the PARP inhibition we'll get into in a little more detail, and really what we're dealing with here is this understanding of the fact that you have to repair the DNA every day, as we said. The BRCA is responsible for double-strand DNA repair. That PARP pathway is responsible for single-strand DNA repair. So what happens is if you inhibit the PARP pathways, you get double-strand breaks. These double-strand breaks, if they're not repaired because you have a BRCA deficiency, lead to cell death. And so this concept of taking advantage of one existing DNA repair pathway problem and then drugging the other problem is known as synthetic lethality, and it allows these PARP inhibitors to be extremely effective in patients who have these mutations, and we'll give you some examples here. So if we look at the different structures of some of the more common PARP inhibitors that we have out there, rucaparib, veliparib, olaparib, niraparib, see here that they vary in terms of their chemical differentiation, and we're not going to get into all the details tonight because, as I said, this is really an hour-long talk in and of itself. But this gives you an overview of what companies are involved, what the different drug names are, and some of the trials of where they are and where they stand in terms of approval and so forth. So in general, we think that most of these drugs are fairly similar, although there are some differences in terms of the binding and the half-life and some other things that could affect efficacy. But from what we're seeing so far, they've all been pretty effective in the trials, and certainly we'll see more data come out as we move forward.
And I'm sure it's so confusing for patients as well as care providers and physicians that there's currently, we have 5 drugs listed here, but currently really 4 drugs that have been tested or in testing in ovarian cancer, and there's 3 drugs that are FDA approved, and they're approved for all these different, different indications, and when to use which PARP inhibitor. So I'm sure some of our patients are confused as well.
Well, I think clinicians are really confused. I saw a patient this week that was really interesting. The physician said that she wasn't eligible for a PARP inhibitor based on some interesting things. She had a germline mutation, of all things. Said she wasn't eligible even though she had 2 prior lines, and interestingly, she was responding to her latest platinum line. So I explained to them she was actually eligible for 2 PARPs that are on the market right now. And all these labels, I think, will start to come a little bit closer together because all these companies have studies out that sort of look at some of the holes in their label, where I think we'll see the labels look a lot more similar than different in the next year or so. So it's really an interesting time.
I absolutely agree. But for all of you who are listening and looking at that table thinking you're confused as well, Tom is going to go through these next few slides and clear up any confusion for you, right?
Sure. So this is looking, again, at the 3 biggies, if you will, that are currently approved in ovarian cancer. So olaparib, that's currently approved for 4th line and beyond. Rucaparib, that's approved for after 2 chemotherapies, and then niraparib for maintenance platinum-sensitive disease after a response to the antecedent platinum. So as I said, I wouldn't get too hung up on the labels because I think they're going to start to merge in terms of, or look more similar as we move forward, as other phase 3 studies report. You can see here these differences. We see the PFS of some of the data here. That's progression-free survival. So that's how long you either live or how long you live until a recurrence. And as you can see here, pretty interesting results with what we call hazard ratios. So we look at what the risk of reduction is if you're exposed to this drug. So in the case of olaparib, for example, if the hazard ratio is 0.3, that means there's a 70% decrease in the risk of progression if you're exposed to the PARP inhibitor versus a placebo. So really impressive data. In niraparib, we see similar hazard ratio. Rucaparib, we expect to see some data that will be in that same setting coming out later this year.
And I just want to say, how reassuring is it that you have two separate trial designs, right? Two separate PARP inhibitors and such similar findings across the board, not just with hazard ratios. I mean, hazard ratios are the same essentially, right? Yeah. But also the magnitude of benefit with both of these studies, 19.1 months for olaparib in women who have the germline mutation, correct, versus 5.5 months. And then with niraparib in the patients that have the germline mutation, 21 versus 5.5 months. That's very similar, and I think very reassuring that both of these studies independently had such similar results.
And to your point, the placebos were exactly the same in those. Yeah. So it'll be very interesting to see the rucaparib data in Aerial 3, which will be similar type of setup, so we can see this. So current approvals, I went through those. You can see them there listed under current FDA approval, and then the different studies that have been done to support those approvals as we see them right now. Now, I think that most of us would say that we think that these are, at least clinically, fairly similar in terms of efficacy. And there may be some things that get teased out in later analysis of some of these large data sets where we can do subset analysis and so forth. But I don't know about you, but for me, they're fairly similar in terms of efficacy. Where we do see some differences, though, is in the types of toxicity. So we see a class effect with PARP inhibition that goes across all three of the drugs, but the degree of toxicity that we see is somewhat variable in some of these. So with olaparib, certainly there was, at least in some of the data, some concern with nausea, vomiting, anemia, and so forth. But overall, pretty well tolerated. One of the problems olaparib faced early on was the high pill burden, 16 pills, and the move now from capsules to tablets, we think will certainly mitigate that issue. Rucaparib, we see a fair amount of anemia. We also see some concern with increase in liver function tests. And then the biggest issue that we've really seen with niraparib has been a fairly high rate of thrombocytopenia. Grade 3-4 has been 34%. So that's pretty significant. And anemia is 25%. So it hits the bone marrow a little bit harder, and it also has some effects that are a little unusual in terms of hypertension. They're all, to some degree or other, associated with fatigue, but that's always difficult in ovarian cancer to separate that out.
So, Tom, do you think some of these differences may be dose-related?
I do. So, for example, what's interesting with the niraparib data is that they say, well, you can just lower the dose, and they indeed had a significant number of dose reductions in the large trial, the NOVA trial. And what's interesting is from the data, from what we can tell anyway, they maintain efficacy at the first dose reduction, which begs the question, could you treat them at the lower dose? And are you really looking at the same doses across all these drugs? And I think it goes back to how we develop drugs in general, right? We look for the maximally tolerated dose. We don't always look for the minimally effective dose, and it can be a challenge.
That optimal biologic dose. You know, the other area here, too, is the capsules for olaparib are currently what's on the market. The tablets are on clinical trials. So for our patients out there that are on olaparib, if you're interested in it, tablets, it's not available yet. My hope, though, in terms of our experience with the tablet, there is less GI toxicity, less nausea and vomiting. My hope is that we'll get an indication for the tablet as well, so that will be available to our patients.
All right. What's interesting is, you know, going back to this whole PARP inhibition story, is that really the first thing that I think piqued our interest was the phase 1 study that came out in the New England Journal of Medicine in 2009 by Dr. Fong and associates. And we then saw olaparib developed across a number of different tumor types, and one of the studies was a fairly simple phase 2 looking at response rate, and what they found was over 30% response rate in a mix of platinum-sensitive and platinum-resistant patients, which really led to the original approval, provisional approval for this. So it was quite interesting looking at that, and that's led then to all these companies developing phase 3 studies, and we're getting a little long on the PARP inhibitors, but niraparib maintenance trial that we talked about, the NOVA trial, has been also reported in the New England Journal of Medicine. And we just want to take you through just some understanding of how we use these biomarkers, very importantly. So if we look at those that had germline mutations, we already presented this data. It was 21 months versus 5.5 months in terms of progression-free survival, and the difference obviously being pretty profound and obviously highly statistically significant, with gaining 15.5 months. Then if you broke it down into the patients that did not have a germline mutation but had this homologous recombination deficiency, had those other gene defects that we talked about from the beginning here, you still saw a significant difference with an impressive hazard ratio. So here you're reducing your risk significantly, again, by 62%. And then overall, looking at the patients, still a significant difference. And what was interesting is there was still a statistical difference for those patients that were non-germline and did not have HRD, begging the question, do all patients benefit from PARP inhibitor? And I think all of us have different feelings about that, and I don't know what yours are.
Yeah, I know you're going to delve into this a little bit. I know you're going to delve into that more. Do you mind going back to that one we just did?
Yeah.
Because this middle column, that non-germline BRCA mutation group that's HRD positive, that included women who had a somatic mutation. Remember, Tom had mentioned if you have a somatic mutation, you didn't inherit the mutation, but your tumor developed that mutation.
Right.
And that's not, it happens about 6% of the time,
right,
based on some of the data we have. So it's not really common, but that is a driver in that group. And you're going to show us some graphs later that separate that out. And this overall non-germline mutation cohort, that study was set up in two buckets, right? The germline bucket and the non-germline bucket. But one of the most important things is that we found, we're thinking, oh, this trial is going to show us which patients to treat. But actually, the drug got approved for all comers based on this data, because even though the benefit was smaller in the other group, it was still a benefit.
Right. Right.
So,
it's statistically significant, but a lot of us are sort of scratching our heads because I think a lot of us were excited that we were entering our biomarker-driven world. And
the more you learn, the more you realize you need to learn.
Exactly. So then after those approvals, we had rucaparib approved based off of a combination of Study 10 and Aerial 2 data. And the Aerial 2 data looked at patients relapsed platinum-sensitive ovarian cancer in Part 1, and then it went in and actually included patients that were platinum-resistant in the second part of the trial. So
yeah, I should probably put that slide before the NOVA data, because rucaparib was approved in December of 2016, and then the niraparib drug in NOVA was approved just this past
right.
A month or so ago, right, in April. So that was my fault.
So we had two very quick approvals, PARP inhibitors to join olaparib, which had been approved earlier, but again, for a fairly limited label of germline only and for fourth line and beyond. So it's a fairly limited label, and these last labels are certainly much broader, so very interesting. But as I said, again, these labels I think will be changing over time as more studies report. So this is looking at the primary efficacy analysis from the Aerial 2 study, looking at the PFS differences again. And as you can see, really impressive hazard ratio there in the BRCA mutated patients. Very impressive in terms of hazard ratio of almost an 80% reduction in the risk of progressing, which is we just don't normally see hazard ratios like this in ovarian cancer that are treated with traditional chemotherapeutics.
And then the thing I thought was really neat about this study is this was a tumor mutation, so it combined, right? If you had the germline mutation or a somatic mutation, those were combined together in that group.
Speaking, of course, to their label, which includes somatic mutations as well. And so certainly exciting data. And then this is looking at the BRCA-like versus biomarker negative, and you can see they also did better. With what would traditionally be a great hazard ratio if it was chemotherapeutic, so 33% reduction in the risk of progression. So all very impressive. So All right, well, let's turn it back over to Angeles and talk a little bit about current treatments for ovarian cancer.
That was a great overview. I love seeing that data because for me, when we did receive approval for the PARP inhibitors, it was as if a whole new world opened up what I could offer my patients in the clinic. So really exciting forward motion there. I'm going to talk about current treatments in ovarian cancer, and then Tom's going to expand on that in terms of where we go now with our information that we have. And what's wonderful about this slide is it's become very busy, and it just shows a timeline starting all the way in 1978 to where we are today in 2017 and the drugs that were available. Back in 1978, really cisplatin was a cornerstone of therapy, and it was for decades, right?
Right.
I mean, carboplatin became available and was approved in 1989, but it wasn't until the mid-90s that there was a study that revealed that adding carboplatin to taxane, you had a similar benefit compared to cisplatin and much less toxicity. And then some really, a drug, altritamine, that I haven't used in years. And then we have this kind of introduction of all these different agents, and it goes a little haywire, but you can see that in 2006, we had approvals for full approval for liposomal doxorubicin, as well as a combination of gemcitabine and carboplatin. And the gemcitabine and carboplatin combination was specifically for women who had platinum-sensitive recurrent ovarian cancer. And then it was nothing for 8 years. I didn't reflect the time on this timeline that well because it looks small, but it was 8 years before we had another approval, and that was with bevacizumab and chemotherapy for women who had platinum-resistant ovarian cancer, and I should probably explain that a little bit more. Platinum-sensitive ovarian cancer denotes somebody who's had a recurrence of their cancer, but it's been at least 6 months since they completed their initial chemotherapy, whereas platinum-resistant ovarian cancer refers to those patients who have a recurrence and it's been less than 6 months after they completed their frontline therapy. So after that 2014 approval, then we had the olaparib approval, specifically the fourth line and beyond for women who had a germline mutation, and a lot of different clinical trials being done, and then chemotherapy and bevacizumab were approved for platinum-sensitive disease in 2016. And following on the heels of that approval, we had rucaparib, as you mentioned, and then most recently niraparib, just in April. So it basically what all this shows is just how many different options we have for our patients now. So let me move on to what is the common way that women are treated. And for the patients on the call, you're all very familiar with this in terms of the symptoms that you have and the diagnosis. I just want to impart how important it is to recognize those symptoms early. Often women will have symptoms, but there's still a delay till they're diagnosed. And it's so important to understand and to be a strong advocate for yourself and for family members that if you have pelvic pain or discomfort, bloating, feeling full early, or changes in your urination with increased urination that happen daily for 2 to 3 weeks, then that should be a trigger to contact your physician. You know, as a woman, and Tom, you probably don't experience this too often, but we have some of those symptoms that occur every once in a while. So if it's something that just happens sporadically, it's not something to get alarmed about. But if it's something that you have daily for 2 to 3 weeks, then please contact your physician. In terms of initial diagnosis, you may have primary surgery, to either a big surgery, try to remove as much of the tumor as you can, or maybe a smaller surgery for diagnosis and try to understand where the cancer has gone, followed by chemotherapy. Or sometimes people are treated with chemotherapy first, and then the bigger surgery followed by more chemotherapy. And the good news is a lot of our patients with ovarian cancer are able to get into remission. I think it's amazing how this cancer can be widely spread and still responds and so sensitive to chemotherapy that I would say, you know, anywhere from probably about 80% of our patients are able to get into remission. Is that been your experience too,
yes.
Tom?
Mm-hmm.
Yeah. The hard part is that sometimes this cancer will come back. And that's why we monitor and watch our patients closely, have them return to clinic every few months for a complete exam. And I'll often use the CA-125 tumor marker to assess for patients in that situation, and it kind of is a trigger for, do we need to do further assessment, a CT scan, and so forth. And then next I want to just focus on some of the new information in terms of if somebody does have a recurrence, how do we recommend, what kind of treatments do we recommend? I think it's so important to understand the biology of ovarian cancer. Like we talked about before, there's not just one type, and how these different types can determine what your doctor recommends for you in terms of treatment. So some patients may know what subtype of cancer they have. If you don't, I would recommend that you do ask your provider, because that type can determine if you're eligible for some of these treatments that we've talked about. And then it's really important to understand if you have the BRCA mutation, like Tom mentioned. That's one of the reasons why we do recommend genetic counseling, is that this has information that could be helpful to you in terms of understanding your prognosis, but also predict if you're going to benefit from a PARP inhibitor, as well as inform family members. So it's really important to understand, do you have that mutation, or do you have a BRCA-like tumor? We're understanding more and more about what it means to have a BRCA-like tumor, and there's other tests that are being done. And versus, do you have a tumor that doesn't have a BRCA mutation, it's not acting in a BRCA-like manner? Should you have other treatments? Or, there's a lot of interest right now in terms of adding other drugs to PARP inhibitors that I think Tom will spend some time on. The other thing we evaluate, too, is that treatment-free interval. I briefly talked about platinum-sensitive versus platinum recurrence based on 6 months. Some of the this new classification, actually, Tom, you wrote this paper. You helped write this paper, right?
I did.
Was this 3 months versus 3 to 12 months versus greater than 12 months? So a little bit of a change. Do you want to explain why you all made those changes based on time intervals?
Yeah, so I think that, we don't want to ignore the great work that's been done in terms of the traditional classification of platinum-resistant versus platinum-sensitive. But we have to be cognizant of all the new developments. We've been sharing those with clinicians who may be listening tonight, as well as patients who may be listening tonight, about how important the cell type is under the microscope, so the histology, what the molecular signature are. We talked a lot about BRCA, but there's other ones that we mentioned as well. And then we clearly have a better understanding now that that there's a spectrum in terms of the interval. And so I think what we really need to do moving forward is we need to appreciate the fact that we can probably do a better job of breaking these platinum intervals into smaller subgroups and be more accurate. And even the 6 to 12 month group is different than greater than 12 months. So I think we're learning more and more. And then the line of therapy can also be important. And we're seeing some of that in the indications for PARP inhibition, for example.
Right. So going back to treatment-free interval, I just want to kind of bring it back to the patient level in terms of what they should be thinking. That greater than 12 months, that's really reassuring. That's a group that has a really high likelihood of benefiting, again, from going back to their initial chemotherapy, and that's probably a group that's going to have potentially better benefit from a PARP inhibitor. We're not 100% sure yet how that's going to work out, but that's the way some of the data looks right now. And then that less than 3 month group, they're less likely to benefit by going back to that chemotherapy regimen and looking at other drugs may be better for those patients. And then that number of prior chemotherapy regimens, was that 3 or fewer or greater than 3? Was that based on the indication for olaparib?
It was.
Okay.
So just showing that there's perhaps another regulatory pathway forward for approval based on the number of lines.
So it just shows how fast things shift, because now I wouldn't necessarily have that number of prior therapies in there. There is some information that indicates using a PARP inhibitor earlier makes sense. We do have a question from one of our patients who has a low-grade serous cancer, and could PARP inhibitors work in that situation? And Tom showed a chart of low-grade serous cancers can also have mutations in BRCA1 or 2. So I would say in that situation, it's important to talk to your doctor about if your tumor has been tested for these mutations. and there's certain tests that can be done to evaluate that. And I would recommend choosing a therapy based on that tumor evaluation. If you do have a BRCA1 or 2 mutation, you may benefit from a PARP inhibitor. If you have one of those other mutations we talked about, like a KRAS mutation, then there's other different treatment options that may be of interest to you. And Tom's actually going to start talking about how do you take all this information that we gave you and individualize that.
Right. So we're gonna go through some of this pretty quickly because I think it's important that we have a little time for questions. And also, while this is of great interest to Angela's and myself, because I think we spend quite a bit of our free time trying to develop better treatments for ovarian cancer patients, some of this will come to fruition. And some of it won't. So I think that that's something that we need to keep in mind. But really the big question is, can we do better than what we're currently doing? So what I've tried to show here is that you have a population, and that's sort of how we have things right now, is that everyone looks the same, right? If you have ovarian cancer, you have ovarian cancer. And as you've seen from some of the data that we've shown you tonight, and I apologize if some of this has been over the head of patients because we've geared it to both patients and to clinicians, and so I think it's important that we try to have something for everyone here. But for patients, I want you to understand that we've traditionally treated all ovarian cancer patients pretty similarly, and in fact, 5 years ago, everybody was pretty much getting the same therapies, and the algorithms were pretty tight. And now with all the new things that have come out, those have changed. So what we want to do is be able to say, if you're a blue patient, will you respond to a blue pill? If you're a gold patient, will you respond to a yellow pill, and so forth. And so those are the things that we've really worked on. And it's been due to a number of areas that have improved, that have really been promoting our ability to start the foray into personalized medicine or precision medicine or whatever you want to call it, where we give the right drug to the right patient at the right time. And so we have a lot better management of data than what we've ever had. We can interrogate a lot of changes in the DNA that we weren't able to do before. As I mentioned, and we can do this much more cost effectively than what we used to be able to do. So why targeted therapies? Well, we think that we can overcome some of the drug resistance we see with traditional chemotherapy. We think we might be able to, in many cases, target the tumor itself without other cells being affected as much. So it's much more specific. We see different toxicities with this, and it's certainly appealing, right, intellectually, that we're going to have a protein or a pathway that's overexpressed in the cancer, and we're going to target that specifically, and we're going to go after that. So it makes a lot of sense on that level. There's still challenges, though. When we measure all these changes in DNA, which of these are important? Which of these are bystander effects, and which of these are the driver mutations or the central mutations that actually cause the cancer to be the cancer? And so all these things are of challenge. Certainly costs of these therapies and so forth are interesting. Just wanted to show this very quickly. This is from the TCGA project, where they did large analysis of chromosomal defects. And what you're looking at, let's not worry about lung cancer. Let's just look at the top two panels, ovarian and glioblastoma multiforme, which is a brain tumor. And if you look at the changes there, with the red being an amplification and blue being a deletion, you can see there's two hot spots. Chromosome 7 and chromosome 10, where you gain DNA in chromosome 7, the red, and you lose it in chromosome 10. Now compare that to the panel above for ovarian cancer. So it's much harder to say that one single mutation is going to be targetable. So we think that we're going to have to break out these ovarian cancers and have a better understanding of who to treat and how as we move forward. And I think that that's something that's really important going forward. One of the things that I think is important is to understand that we are starting to, with even rare tumors in ovarian cancer, design clinical trials that will be different than the traditional treatment options that we've had available. And this is just a list of some of the things that have been out there, including low-grade serous, mucinous tumors, and clear cell tumors, which have been very challenging for us to treat with some of the traditional chemotherapeutic drugs.
I just want to turn the audience's attention to the middle of that table, GOG 281, such an exciting trial for women with low-grade serous cancers. Just closed to enrollment, right?
Right.
And that was evaluating a novel MEK inhibitor, so targeting those mutations that we mentioned before. And I had some patients, and the way the study was designed is you could treat with standard of care therapy as well as a study drug. And I had some patients that had stable disease on standard of care therapy, got to the study drug, and had these great responses in CA-125. So we don't know how this is all going to work out yet, but it was really exciting.
I have someone still on the Milo trial that's still responding, even though the trial is closed. So it's really fun when you see these types. You get in the lab, you discover these associations, but then you're able to bring it to the bedside and see the dramatic effects that we see. And speaking of dramatic effects, there's been a great interest recently in immuno-oncology. I call it immunomania in the sense of if you go to ASCO the last 2 years, the majority of plenary presentations have included some type of drug that included an immune-type agent. And so we've seen some major breakthroughs. And just recently, was it 10 days ago or so, we had an approval for Pembro, I think it was just last week, for microsatellite instability high cancers. And what that means is that for some of those that have those genes, again, in this case mismatch repair genes, that we can use this drug that's a checkpoint inhibitor, and we'll talk a little bit about what that means in a second. But what's so exciting about this is agnostic as to the tumor type, right?
Right.
So it doesn't care whether you have an endometrial cancer or renal cancer or what have you, as long as you have these genetic changes. So again, you can see how we're getting closer to this personalized medicine based on the genetic changes.
I just want to use this slide as an opportunity to highlight to our patients that with the approval of this drug, this might be something you want to talk to your doctors about to have them see if you have a microsatellite instability high tumor. We actually have somebody who's asked a question on our presentation today that talks about an endometriosis-related cancer that's stage 3. And some of these endometrioid cancers may have a higher incidence of microsatellite instability. So for that patient, I would talk to your doctor about testing for that, which can be done. And if you have the MSI high tumor, you may be a candidate for pembrolizumab. We like to, on this presentation, Tom and I are trying to stay with the generic names. We're asked to do that. So sometimes, all these drugs have 2 or 3 different names, right? It can get kind of confusing. But that is what I would strongly consider. And you're going to show this information about
well, I wasn't even going to show this slide, but when you said endometriosis and we were addressing that question, you can see the endometrioid subtype, which we think can arise in some cases from endometriosis. We see common changes there that may make them a candidate for pembrolizumab. So very interesting in terms of looking at this. So right now we're moving towards where we're doing more trials, and one of the things is a molecular analysis of therapy choice, which is known as the NCI MATCH trial. So the National Cancer Institute is doing a trial that's based on biopsies of the tumor. So now, again, we're interested more in what are the mutations that are present in your tumor rather than where did your tumor come from. Up till now, we've always been interested in where did your tumor come from only. So if it was lung cancer, that was a whole different set of studies. If it was renal cancer, a whole different set of studies. And now we find if it's a clear cell of the ovary, well, that may be very much like a clear cell of the kidney. And so maybe those patients should be put on the same trial because we're really going after the same type of genetic mutation.
Right.
And so it's really exciting in terms of some of the things that are going on in that, and we see quite a bit of interest in the MATCH trial moving forward. And so I think finally, to wrap this up, I just wanted to mention this whole idea of these PD-1 and PD-L1 checkpoint inhibitors, and then there's another one, CTLA-4. Again, probably over your head if you're a patient, but important for you to understand that these are out there. And if you're speaking to your physician, you would just say, what about the immune drugs or what about the checkpoint inhibitors? Would they have a role? And this really involves the immune system really being turned on to the cancer. So how does a cancer grow? Well, one of the problems with cancer is it's not recognized as a foreign protein that's present in your body. Normally, your body rejects any foreign material that's in there, and it does so on a daily basis because it's faced with these types of decisions over and over. But what happens with cancer is that it's able to evade the host immune system, and what we are doing with these immune drugs is we are reactivating your immune system against your cancer. And there's different ways of doing that with vaccines, with these checkpoint inhibitors. It's a really exciting field. And one of the areas that's also exciting is to combine these different drugs. So as we move forward, I think you'll see more and more in the way of combinations, and we have some examples here of where some of these checkpoint inhibitors are put together with VEGF or anti-angiogenesis agents. We know there are a number of trials with PARP inhibitors that we've talked about, and you see here with traditional chemotherapeutics as well. So it's really an exciting time in ovarian cancer from the standpoint of the pipeline. I don't think has been this rich in many, many years, and we've seen more developments in the last 3 to 5 years than what we've seen in the previous 15 to 20.
So I think the important message for what you just showed the patients there is talking to your doctors about new treatment options, talking about immunotherapies, asking if you're a candidate for a PARP inhibitor. And then just in quick review, what we did today is review the ovarian cancer incidence, the origin, and management. Ovarian cancer is a rare disease. We know there's several different subtypes. It's not just one subtype. And the cornerstone of management is surgery and chemotherapy and some of these new drugs coming onto the scene, and survival continues to improve.
We've also discussed the genetic testing, the importance of the testing in all women with ovarian cancer, and how genetic testing has treatment implications besides clinical value in prognosis, and testing relatives as well. So that's the cascade testing. So testing those relatives to identify these cases before they even occur.
We reviewed the current treatments for ovarian cancer and the use of PARP inhibitors and several different indications.
And we've hopefully given you some insights on enhancing your understanding of this personalized medicine or individualized therapy for ovarian cancer. We've started with the concept that there's different cell types based on what it looks like under the microscope, and we've now evolved to understand which mutations are important moving forward, and we now have treatment strategies around some of these mutations that we've been able to identify. So biomarker or mutation-driven therapies. So I think now what we'll do is try to get into some of the questions that you've asked in our remaining time.
Yeah, we have so many questions.
Yeah.
This is wonderful. So one of our patients asked if her CA-125 was never that high at the time of diagnosis, what other markers are there that can be evaluated? So CA-125, about 20% of women with advanced stage ovarian cancer will have a normal CA-125. And in that situation, what I usually use is imaging. I know some individuals may use an HE4, but in my experience, my best step in that situation is getting the CT scans and the physical exam. It's very important. Do you have anything else to add there, Tom?
No, I think that's true. And I do think there could be other markers that are on the horizon, but we'll leave it at that.
And then we have some other questions, too. This is a patient right here that talks about Foundation 1 testing for, I guess it was the Foundation 1 platform testing for a whole bunch of different genes, like 315 genetic mutations. It was done in 2015, and is it as up-to-date as possible, or should patient be retreated? Or she must have had it done in 2015.
Right.
And should she have it done again? Oh, this is a great question.
It's a great question, right.
We're just talking today, Tom, right, about how some of these mutations, we're specifically talking about BRCA 1 or 2 mutations, can undergo a second mutation, so then it's not sensitive to PARP inhibitors.
Right.
So this is 2017 at this point. This is, I think it's an interesting question. If you're going to consider treatment on the MATCH trial, I think it's reasonable to rebiopsy the tumor. if you're not going to get treated on the MAT trial, which is the trial Tom just talked about, I don't know how easy it would...
Or another trial, because there's a number of trials that require new biopsies.
Yeah, I don't know if you would be able to get this test done, but I would be tempted to, but again, it's a...
Yeah, my response to that would be it depends on how you're doing. It depends on what's on the table as treatment options, and certainly if there's a clinical trial that is very interesting that demands retesting, I would consider doing that strongly. It also depends on how easy is it to do the biopsy. So some people have tissue that's readily available in terms of it's in an easy area to biopsy. In other areas, it's in a critical area surrounded by structures that even the interventional radiologist doesn't feel comfortable probing with a needle. So I think that all those things come into it. What we do know is that these tumors do change over time, to Anjali's point. So we know that some of these mutations can actually revert, as we mentioned, but you can also develop new mutations. And so 2015 is not that long, but there could be some changes. Certainly, if we were looking at 4 or 5 years, I think we'd be even more strongly encouraging you to have a rebiopsy.
Our next question comes from a patient who had stage 3, grade 3 serous cancer of the fallopian tube, and she had an optimal debulking surgery, so they were able to get out almost all of her cancer, if not all of it, and she was treated with chemotherapy, with belly wash therapy, also known as intraperitoneal chemotherapy. And then she was diagnosed with enlarged lymph nodes, and those were removed. And then she got more chemotherapy with gemcitabine and bevacizumab. And then that was followed with carboplatin and liposomal doxorubicin because her CA-125 increased, and then radiation. And then recently diagnosed with recurrence in April, and she was started on carboplatin and docetaxel. And she's asking about a PARP inhibitor. So, she has had... she got carboplatin with the gemcitabine. So she's had several lines of platinum-based therapy. It would really depend. I mean, it sounds like she may be responding. We're not sure about that. She just finished her 3rd round. This is a little different than the patients who participated in NOVA, but, you could talk to her about a PARP inhibitor with niraparib because it was approved for all comers.
I agree.
So that would, the benefit, if you're biomarker negative group, that benefit was about... It was still a significant hazard ratio. Was it 0.58? It was probably about a 40% reduction before your cancer came back. And I think it was about a 3 months. If you look at the actual months involved, it was about 3-month benefit. In terms of the Foundation 1 testing you had a KRAS mutation, some other mutations there, but I would focus more on KRAS. And there are some drugs that target that. So you do have some options here.
Right, and P53, which has traditionally been very difficult for us to target, but it's a very common mutation with these ovarian cancers. But there's a number of different things in the pipeline right now, WEE inhibitors and so on, that are looking at P53, so it'd be interesting. I think we both would agree that you could probably benefit from being off platinum because you've had quite a bit of platinum, probably. We don't know how many. And again, with any of these individual questions, we'll try to help you out a little bit. But it's a little bit hard because your physician knows your history so much better, and we really can't make specific recommendations, obviously, but certainly can make some general recommendations in terms of things to talk to your physician about.
The next question are CTLA-4 and PD-PD-L1 tested, and those are the some of the biomarkers that we mentioned that are involved in immune system. And are those tested through Germline or Somatic screening? I would test those through Somatic screening tests, and those tests are currently done. Like if you have testing done through any of those platforms, they will assess for expression of these proteins.
And we didn't get into a lot of the details, but you have antigen presenting cells, and you have T lymphocytes and so forth, and then you have the tumor, and there's an interaction between these, and that's really where these different PD-1, PD-L1 come into play because there's binding between these, and you can inhibit that binding and change the immune tolerance. What's
amazing to me with the immune system, there's these different variations, right? So there's when they've gotten tumor from patients and they've looked at the immune cells, some of the tumors don't have the immune cells there at all. Some of the tumors have the immune cells there, but they're not able to function because the cancer is so smart, it blocks them.
Blocking.
And then sometimes the immune cells are there and they're able to function. So there's all these different type of landscapes, if you will. But what's so
what's going on in the microenvironment or the environment around the tumor itself.
And what's so cool about these immunotherapies, and the way I like to think about it is some of them unlock that ability, or make it capable for your immune system to function, which is really neat. All right, so we have a question about the side effects of some of the new treatments, and I know you had that slide in there, Tom, that went through some of the side effects of the PARP inhibitors.
But even beyond that, so we talked about the PARP inhibitors, but you have the immune agents, and you have some very interesting. You have a little bit of a trade-off. So the thought behind all these targeted therapies would be that you would have very little in the way of side effects, which hasn't always been the case, and that's something that needs to be kept in mind. For example, with some of these immune agents, we see some significant organ inflammation, pneumonitis, hepatitis, colitis.
Yeah, and so for our patients, pneumonitis means inflammation of the lungs.
Yep.
And hepatitis means inflammation of the liver, and colitis means inflammation of the
bowel.
So with
bowel,
and
you can have it of the kidneys.
So with the colitis, patients will complain of diarrhea. And you also have to monitor the thyroid closely and the adrenal glands. Some patients can have a situation where it limits the ability of the adrenal gland to release important hormones. So
right. It's just
very different things to watch for.
Yeah, I think the key is really talking to your physician about the drug and what kind of side effects would you likely see, and what are some of the other more serious side effects that have been reported in association with the drug. I think those are two important questions to ask before you go on any of these drugs. We're seeing some very strange things, though. I mean, even with like the MEK inhibitors for low-grade serous, we've seen ocular changes and some very interesting things that have gone on. Skin changes, rashes, all kinds of things that we didn't see with traditional chemotherapeutics.
Right. Well, Tom, anything you want to add?
Well, I think that it's just such an exciting time, and I hope our overexuberance didn't get into too much detail, that we're taking the patients down a river of the unknown. But I hope they understand. I think that the key thing is that there's a lot of new things that are out there. So you want to make sure that your treatment and provider team is in sync with a lot of the new developments, and that they understand the disease course, as well as all the new trials and the new treatments that are out there, and that they treat a sufficient number of ovarian cancers to be able to deliver this knowledge on an individual level to their patients.
Right, and for our patients too, important to ask about chemotherapies, but beyond that, bevacizumab and the PARP inhibitors have for you, those would be questions that I would be asking my doctor. Right now, they're not available in the frontline setting. Well, bevacizumab is, but it's not approved in the United States, so it can be hard to get that for some patients. But those would be questions to ask definitely if you had a recurrence. And then asking about clinical trial opportunities.
Yeah.
Oh, we do have one more question, and this is from a patient who has been blessed 5 years now off of treatment for stage 3C ovarian cancer. And that's awesome news. Your BRCA testing was negative and no family history. And you're wondering about CA-125 as adequate surveillance. I think so. I think CA-125, if it was a marker for you, that is what I use for my patients. I get imaging based on if I feel something on exam that I'm concerned about, or my patient has symptoms. And by doing it that way, you're following guidelines, right, currently released by our society, but also you reduce the radiation exposure from the imaging. Tom, do you do anything different?
No, I'm a big proponent. If you're in that 80% who overexpress CA-125 when the cancer is present, I'm a big believer in using that in surveillance more so than routine imaging, which CA-125 is more sensitive. It goes up before the imaging is positive. And to your point, it's so much better in terms of avoiding that radiation.
And then also, the audience member asked, are successful tumors like hers being studied? And yes, they are. You are called an exceptional responder. And there are studies evaluating tumors from patients who are exceptional responders, not just with ovarian cancer, but a variety of other cancers. And then also you had asked about the fact that you had fibroids and endometriosis. And at the point when you were diagnosed, I don't think they really understood that link with endometriosis and ovarian cancer as well. But since then, a paper came out that reported that women who have a history of endometriosis are about twofold increased risk of clear cell and endometrioid cancers. And it seemed to be specific types of cancers, not necessarily the high-grade serous. So I do have some patients who don't have cancer in my practice. If they're diagnosed with endometriosis, I do discuss that with them now. But I also put that in the context that this is such a rare disease, 1 in 70 women, so about 1.4%. So if you're increasing that twofold, it's still a really low percentage, but it is important to have that discussion with your patients about that potential risk.
Yeah, agreed.
So congratulations, that's wonderful news.
So the other things we didn't really talk about, and just in terms of time, was surgical intervention and secondary cytoreduction. There's a lot of other things to talk about and to think about with ovarian cancers. But again, I think these are the types of discussions that are so germane with your treating physician.
Absolutely, and there's going to be some exciting studies presented about secondary surgical cytoreduction, and what that means for our audience is, if you've had a recurrence, is there a role to go back and do more surgery? And so stay tuned. We might have updates on that in a few months.
That's right.
Right, thank you so much. On behalf of FWC, I'd like to thank all of our attendees for joining us today and for all of your great questions. I'd also like to give a big thank you to our speakers for their great presentation. Before you shut down today, I'd ask that you take a moment to please fill out the brief survey you'll see on your screen. SGO and FWC appreciate your feedback in order to help improve future webinars for you. Again, thank you so much for joining. We hope you have a wonderful day.